This is a presentation on acute bacterial meningitis. The learning objectives of the presentation are to know the common pathogens causing acute meningitis, to understand the pathophysiologic process of meningitis and the mechanisms by which complications of meningitis occur, to identify characteristic profiles of cerebrospinal fluid or CSF in meningitis, and to identify meningitis as a medical emergency and understand its management. Meningitis is an infection within the subarachnoid space, causing a central nervous system inflammatory reaction and is often characterized by decreased consciousness, seizures, and raised intracranial pressure. It is often caused by bacteria or viruses. Other pathogens like Mycobacterium tuberculosis and fungi usually cause subacute meningitis. Meningitis refers to involvement of meninges alone. When brain tissue is also directly injured, it is referred to as meningoencephalitis. Bacterial meningitis is the most common form of suppurative central nervous system infection with an annual incidence of more than 2.5 cases per 100,000 persons. The epidemiology of bacterial meningitis has changed in recent years due to a dramatic decline of meningitis caused by Haemophilus influenza and Neisseria meningitidis. This is a result of widespread use of vaccinations for these organisms. Streptococcus pneumoniae is the most common organism causing acute bacterial meningitis. This is followed by Neisseria meningitidis, Group B streptococci, and Listeria monocytogenes. Streptococcus pneumoniae accounts for more than 50% of reported acute bacterial meningitis in adults. Risk factors for this form of meningitis are pneumococcal pneumonia, sinusitis or otitis media, alcoholism, diabetes, and splenectomy. Mortality remains high at about 20% despite appropriate antibiotic therapy. Neisseria meningitidis accounts for about 25% of meningitis in adults and about 60% in children. Presence of purpuric and petechial lesions is an important diagnostic clue. The infection is initiated by nasopharyngeal colonization. Individuals with complement deficiencies are highly susceptible to meningococcal infections. The disease can be fulminant, leading to death within hours of symptom onset. Enteric gram-negative bacilli are an increasingly common cause of meningitis, especially in those with debilitating chronic diseases like diabetes, cirrhosis, or alcoholism, and in those with chronic urinary tract infections. It can also complicate neurosurgical procedures such as craniotomies. Group B streptococci or Streptococci agalactiae, previously responsible for many cases of neonatal meningitis, is now an increasingly common cause in individuals over 50 years of age. Listeria monocytogenes is more common in elderly patients and in immunocompromised individuals. Haemophilus influenzae meningitis is declining due to vaccination. Staphylococcal meningitis is associated with neurosurgical procedures and cerebrospinal fluid shunts. Streptococcus pneumoniae and Neisseria meningitidis initially colonize the nasopharynx. They then invade the bloodstream by escaping the immune attack due to its polysaccharide capsule. They infect the choroid plexus of ventricles via bloodstream and gain access to the cerebrospinal fluid or CSF. Bacteria can multiply rapidly within the CSF because of absence of effective host immune defenses. Many of the neurological manifestations and complications of bacterial meningitis result from the immune response to the invading pathogen rather than direct bacteria-induced tissue injury. Neurologic injury can progress even after the CSF has been sterilized by antibiotic therapy. The bacterial invasion and the inflammatory response within the subarachnoid space give rise to multiple pathologic processes. Cerebral edema occurs due to cytotoxic and vasogenic processes. Interstitial edema also occurs. Subarachnoid exudates hamper CSF circulation, leading to hydrocephalus. Edema and hydrocephalus caused raised intracranial pressure and cerebral herniation. Vasculitis of the intracranial vessels affects both arteries and veins, causing infarction, thrombophlebitis, and cerebral venous sinus thrombosis. Cerebral autoregulation is also impaired and in late stages results in decreased blood flow, inducing ischemia and seizures. Acute bacterial meningitis classically presents with the triad of fever, headache, and neck stiffness. Nausea, vomiting, and photophobia are also common symptoms. A decreased level of consciousness is often present and can vary from lethargy to coma. Seizures can occur during any phase of meningitis. Signs of raised intracranial pressure or ICP include decreased level of consciousness, papule edema, and 6 nerve palsy as a fourth localizing sign. Cushing's reflex occurs in extreme raised ICP and presents with bradycardia, hypertension, and irregular respiration. Death may occur due to cerebral herniation. A petechial rash or septic shock would suggest the possibility of meningococci as the underlying pathogen. Neck stiffness is the pathognomonic sign of meningeal irritation. It is present when neck receives passive flexion. Kernicks and Brudzinski signs are classic signs of meningeal irritation. Kernicks sign is elicited with patient in supine position. The thigh is flexed over the abdomen with knee flexed. Attempts to passively extend the knee elicits pain when meningeal irritation is present. Brudzinski sign is elicited with patient in supine position and is positive when passive flexion of the neck results in spontaneous flexion of the hips and knees. Investigations include routine tests like full blood count, ESR, CRP, urea and electrolytes, liver function tests, and a chest X-ray. Blood cultures should preferably be sent prior to commencing antibiotics, but at the same time, antibiotic initiation should not be delayed for blood cultures. Neuroimaging, either CT brain with contrast or MRI brain with contrast, is indicated to exclude focal infections processes like abscess or subdural empyema. Diffuse meningeal enhancement may be seen but is not specific for meningitis. A lumbar puncture should be done if there is no significant raised intracranial pressure. CSF studies are the definitive diagnostic test for meningitis. The CSF profile in meningitis is discussed later. Viral and bacterial meningitis can mimic each other clinically. CSF findings, neuroimaging, and EEG can often help to distinguish them. Subdural empyema and epidural abscess should be considered as differentials, especially when focal neurological deficits are present. Non-infectious conditions like subarachnoid hemorrhage, aseptic meningitis due to drugs, carcinomatous and lymphomatous meningitis, autoimmune conditions can mimic bacterial meningitis. Subacute meningitis due to tuberculosis or fungi are differential diagnosis, and CSF studies are required to diagnose these. In acute bacterial meningitis, the CSF pressure is usually increased. The CSF shows predominantly raised neutrophils, which can range from about 100 to 60,000 per microliter of CSF. CSF protein content is increased and CSF glucose is typically less than 40% of blood glucose level. Please refer to the table for CSF profiles in other forms of meningitis. The choice of antibiotic cover depends on the patient's age and other associated features. Brain imaging and lumbar puncture should not delay the first dose of antibiotic. Immunocompetent adults should be treated with cefotaxime or ceftriaxone and vancomycin. Ampicillin should be added in older adults and in patients with alcoholism or with other debilitating illnesses. Hospital-acquired or post-traumatic meningitis and meningitis in neutropenic patients should be treated with ampicillin plus ceftazidime plus vancomycin. Corticosteroids have been shown to reduce morbidity in streptococcal pneumoniae and tubercular meningitis. Empirical intravenous dexamethasone 10 mg 6-hourly for 4 days, with first dose given with the first antibiotic dose, is a reasonable approach. Raised ICP is a medical emergency and should be treated with urgency. Seizures should be managed accordingly. Mortality following acute bacterial meningitis depends on the underlying pathogen. Neurological sequelae occur in up to 25% of survivors and include decreased intellectual function, memory impairment, seizures, hearing loss and dizziness, and gait disturbances. In summary, acute bacterial meningitis is a medical emergency. Streptococcal pneumoniae and Neisseria meningitidis are the most common bacterial causes of meningitis. CSF examination and neuroimaging are helpful in diagnosis and in excluding other differential diagnosis. Antibiotics should be started as soon as possible, and initial treatment is empirically based on the patient's profile and thus likely underlying pathogen. We hope you have a better understanding of bacterial meningitis. Thank you.